Which one?
This one moves ahead.
This one moves ahead, this one moves back. Higher, here you go.
Move ahead.
So which will be your recommended imaging choice? Show of hands, who will choose a plain radiograph? Who will choose a CT scan? All answers are correct, by the way. Who will choose an MRI? Who will choose a PET CT scan? Okay. So I'll give a case example, something which we had, I think, 2-3 years ago. 44-year-old male who presented with hematuria, painless hematuria, and what will be your initial imaging choice? MRI, CT scan or ultrasound? Okay, painless hematuria, I'll also choose an ultrasound to start with. So we have two choices. Either use an ultrasound to assess the kidneys and the urinary bladder, or you can use, either you use a CT scan to assess the kidney urinary bladder pathology, especially if you're suspecting calculus, or you can do a basic ultrasound. So the doctor who came chose a CTKUB, which once we did the CTKUB, we saw a pathology, which is that, urinary bladder lesion. So what we initially do is immediately change this investigation to an MRI, because we thought we were dealing with a urinary bladder pathology, probably urethral, and why not just stage it directly on an MRI? So we shifted the patient from the CT scan room to MRI room. As you can see here, this is the bone window CT scan, and we are seeing no bone lesion on that patient. You can see the MRI showing us the lesion, anterior, apical anterior of the urinary bladder, very clearly. Anybody who doesn't see that lesion? And what is the additional information we are getting from an MRI? Because once we request for an investigation, the most important thing is what additional information are we looking for? Because every investigation has a cost implication. And what we saw on an MRI is that there's a lesion at L4 vertebral body. Anyone who doesn't see it? Remember, once we did the CT scan, there was nothing on that area. But the MRI is actually showing us a pathology at L4 vertebral body, diffusely involving it. So our suggestion was this is a metastatic disease at L4. So what did the patient do? Patient went for a PET CT scan, which showed a urethral mass, no metastasis, and there was a very low uptake at L4 vertebral body. Uptake means that in a peak ile FDG kidogo, so which was concluded as it's not a metastatic disease. So they went for a radical surgery, removed the lesion in the urethral, and 2 months later, the patient presented with low back pain, can only pray while seated, so we did a repeat lumbar scan. So this is, again, we see our lovely friend at L4. And now on CT scan, we are starting to see the lesion again, starting to show that's almost 2 months later, which we were able to see it 2 months before on an MRI. So what damage has happened? We have wasted 2 months. Patient has undergone a radical surgery. Two things have happened by this point. One, we have an extra osseous extension of the lesion. The lesion has now involved the nerves. That's why the patient cannot pray sawa. Also, we're having liver metastasis, because the patient was treated for curative intent, so no chemotherapy, nothing else. So patients continued undergoing palliative therapy, because now we are no longer having a curative intent. Won several battles, but 2 years later, patient died. So these examples, we can see them a lot. For instance, this is one of our recent cases. You can see the CT scan on the pointer. On this side, there's nothing in the bone, but you can see the very prominent bone lesion on MRI. This is another patient with smoldering multiple myeloma. The CT scan was very clear, yet we are starting to see lesions on MRI. So take-home message is absence of bone metastasis on CT scan doesn't always mean there's no bone metastasis. When you have CT scan and MRI, PET CT scan can say there's a metastasis. There's no metastasis, but MRI can pick it up. So PET CT scan is not always superior to MRI, and vice versa. The next generation tools, which are whole body MRI with diffusion weighted and PET CT scans, are better tools to assess metastatic disease. But remember, do not always push patients for these investigations. They are very expensive and they are time consuming. So you have to tailor from patient to patient, depending on affordability. Unfortunately, in our countries, in our settings, we have a lot of advanced disease on diagnosis. That means probably you can make these diagnoses without a PET or an MRI. And delay of treatment is a very dangerous thing. So don't delay treatment unnecessarily because you want an MR or a CT scan. Thank you very much. Any questions?
Yeah, Dr. Swale, you were so efficient with time that I think we can indulge you a few questions before you leave. If you had looked at your program, Dr. Swale was supposed to speak towards the end of this session, but he has to have an early departure. So we can entertain a few questions. Yes, Jose?
Thank you very much. You made such a fantastic point. I mean, I think it's not really a question, just to emphasize that I think marrying the clinical situation together with multimodal imaging is really the way to go. I mean, you cannot rely on just a single, and for example, that CT scan, I mean, was normal looking. And we've seen that with myeloma and with other tumors presenting obviously with neurological complaints. So I think it's very, very important to take all the pieces of evidence together. And if there is even a suspicion, then go the extra step. And I agree with you that cost is always a factor. But sometimes the cost of not knowing what the problem is and the extent of the problem is also great.
Exactly. Yeah. That's very true. In fact, once you get a report from one end, one person saying there's a metastasis, and another person says there's no metastasis, you need to put those two people together before you even start treatment. Once we ruled out the MRI findings and we gave priority to PET, we all went wrong from that point. Thank you, Dr. Juza. Any other additional comments, questions?
Assalamu alaikum. Mine will be a comment at the same time as a question. I think it's important to understand the role of the diagnostic in managing the patients, okay? Especially when you have these imaging modalities that are with us. So my comment on that is that we should always try and engage radiologists, okay? I'll ask Dr. Muhammad Swale to tell us, how is your engagement with the clinicians, physicians in your day-to-day life? If you work in Mombasa and you never meet your radiologist, you never call your radiologist to understand what the radiologist is thinking, I think we are doing the wrong thing. So we should always engage radiologists. So the radiology department should have a room whereby every time the doctor, the physician, the neurosurgeon finishes the round should end up in the radiology team or in the radiology room for discussion. It's a question and a comment at the same time.
Okay, thank you. Normally we do have interactions, but not all doctors do like interacting. I can actually tell you a case, I think yesterday, when we had a patient with multiple myeloma who came for a whole body CT scan, and we suggested that MRI would be better for this patient. The doctor said, you know what, just do the CT scan. Forget about the MRI. And the patient was able to afford, and we had a slot available at that point. But again, also there are those who come and they do interact. Again, as far as you need to communicate with the doctors, but also us as physicians, we need to be well informed and well updated. Whatever we were taught in school has changed and always changes. There are guidelines, like if you go through oncology, NCCN guidelines, which is free online, you can always see recommendations which are changing every year. I think it's good to be also updated as physicians and know what has changed and which directions we need to check with specific tumors. Not all cancers are the same.
Thanks for a nice talk. In the first case, you mentioned, if I'm not wrong, that the PET scan showed a very mild uptake. In fact, said kidogo sana. Shouldn't this have raised a red flag and would have avoided this long complication?
Actually, it should have, because with the very minor uptake which they have picked, I think the best thing they should have done was to correlate with the other images which were done. Because having a mild uptake on the PET CT scan and having a serious change on an MRI should have alerted them that this is a metastatic disease and handle it accordingly. Even if they were going for radical surgery, they should have also put the patient on chemotherapy. But again, that's interdepartmental lack of communication. One was done in one department, the other done was another area, so nobody communicated with anybody, and nobody reviewed whatever was done in other setting.
Thank you. Can I make another comment? So it's very important to look at all the imaging done in various centers, and sometimes it can be multiple centers. And a lot of my time goes in doing that, and often sitting with the radiologist, and we've sat together also for. So I think it's really, and I'm really grateful to you for bringing that point, and also for your help with the patients that we have seen here. I think it's really, really important to look at all the imaging together. So even if imaging has been done elsewhere, the prints are not enough. Get the data on DVD and look at everything together. The second point I would like to make is that I would go further than Dr. Maalim and say the round should start in the radiology department, so that by the time you reach the patient's bedside, you have an understanding of the data that's been collected from radiology. I think that's really, really helpful. And certainly for example, in Aga Khan in Nairobi, we have a weekly multidisciplinary neuroradiology meeting, and it's really, really helpful to kind of understand the patient's problem before we communicate that understanding to the patient. Thank you very much.
Yeah, I think also the information which the referring physician is providing to the radiologist is important. Because I can tell you, once I was sitting with one of our physicians, and we were looking for on an MRCP, and I was asking, okay, what are the tumor markers? What are the LFTs? And the physician tells me, you know what, just look at the images first. It's like you're looking for a hint, but actually those are the things which guide us to help you. You help us with the clinical information, we can help you better with that.
So may I encourage everybody to, one, participate in these kind of meetings, and I'm sure they can be held locally here. And secondly, to provide information, because really the radiologists are doctors, they're physicians. They have the interests of the patient at heart. They're just not stargazing at the screen. So I think it's important to provide clinical information. This person has a 4-year history of bilateral leg weakness with bladder involvement and has a sensory level at T4. It immediately focuses the radiologist's mind on where to look for a problem. They are not going, they will look at everything else, but they know they have to look very, very hard at T4 and or above. So I think it's really, really important. It's really our duty to provide the radiologist with that information and to discuss the imaging with them. I think it's really important. I think they are an excellent resource which we underuse. Thank you so much.
Thank you. Very good presentation. I just have a thought, and this is towards being a patient's advocate. So when all of these things are done, obviously there's a cost implication to the patient, and if the wrong choice was taken not in favor to the patient, who is meant to pay for that? So I think if we start looking at it from that point of view, where if you do the wrong things, ask for too many investigations or fewer investigations that cost the patient, then somebody will have to pay. And I think if you put that against clinical decision making, sometimes it may improve outcomes. Thank you.
So you're talking about accountability. So the doctors need to be accountable to their patients and accountable to whatever decisions they make on that.
Dr. Hooker and Dr. Maalim, for once, you guys are wrong. The round should begin in the microbiology laboratory. Dr. Swaleh, would you like to make any parting comments?
No, thank you very much. We are happy to have you all here, and always keep updated. Shukran.
So I can say from personal experience that Dr. Swaleh is very, very accessible for the kind of discussions that Juza was advocating. Thank you, Dr. Swaleh, for finding the time to come and talk to us. We can now move on to our next presentation. And so our next presenter is Dr. Jakob. He is a critical care pharmacist with an M.Pharm in clinical pharmacy from the University of Nairobi. He has previously served in Kammp, so he's one of us, as a national council member, chair of Kammp in northeastern Kenya. So this is the first time we'll cheer northeastern Kenya, but we'll find cause to cheer for them later today as well. And he also served as chairman of Pharmaceutical Society of Kenya Coast Branch and also the PSK National Governing Council. He has trained hundreds of pharmacy students, interns, pharmacists, and is actively involved in the CGTRH Antimicrobial Stewardship Committee, of which I have personal experience of his sterling leadership. So Dr. Jakob, please take it away. Thank you for coming to talk to us.
Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the introduction, Dr. Maji. Just want to start with some words of wisdom. There's an Arabic saying which says, Al-hikmah dhalatul mu'min. Aina wajadaha iltaqataha. Say, wisdom or words of wisdom is the lost property of a believer. And wherever you find it, you pick it. It belongs to you. And in the room, we have people from the military, and we have people who understand, who know the Chinese. So there's a Chinese military strategist called Sun Tzu. Sun Tzu is the alleged author of the book called The Art of War. And he has a saying which says, to fight and conquer in all our battles is not supreme excellence. Supreme excellence consists in breaking the enemy's resistance without fighting. And this brings us to my presentation, where we shift gears from imaging towards infectious disease. And I'm going to talk about metrics in antimicrobial stewardship. So when you hear the word metrics, what does it mean? Maybe just a quick question to the floor. When you hear the word metrics, calculation, it's a measurement, yeah? So in metrics basically means a standard or a system of measurement where you measure, you assess, and you compare, all for the purposes of tracking performance. And in antimicrobial stewardship, next slide, the committee usually is there to track and assess the performance. And from the floor, I think we are a mixed group here from different hospitals. How many of us are from a large hospital that is more than 500 beds? More than 500 beds? middle-sized hospital, 200 to 500 beds. So majority of us are from small-sized hospitals. So maybe I can ask very, very quickly, how many of us have an active AMS committee? From among those who had raised their hands. So this must be Aga Khan. Yeah. Any other hospital which has an active AMS committee, apart from Coast General? So none of us has an active committee. KNH, oh yes, KNH. So it tells you a lot about what we are doing in terms of tracking and tracing and preventing the emergence of resistance in our hospitals. So the background is because of the overuse of antimicrobials. There's a rising cases of AMR, antimicrobial resistance. And the WHO and CDC recommend AMS programs to measure and assess the use of antimicrobials. And several stewardship metrics have been described, but not all of them have been validated whether they are of use. And ASP metrics primarily measure antimicrobial use. And although resistance and clinical outcomes are of most importance rather than just monitoring antimicrobial use. So understanding these metrics can assist the committees to monitor and also assess the impacts of their AMS efforts. So primarily, basically, you want to look at pre and post-intervention. Your pre-AMS situation, the way it was, and your post-intervention. Next. So metrics can be categorized basically into mainly three major groups. So one is to measure the process, another is to measure quality, and another is clinical outcome. But it's not limited towards these three. And you'll find most hospitals, basically they focus on antimicrobial use because that is the most available data which is you can find in a hospital. And it's easy to get compared to the rest of the other data. And AMS should focus on clinical impact of your stewardship programs over financial impact. You shouldn't be looking at how much you are saving the hospital in terms of costs, but rather your clinical outcomes for your patients. Next. So the main aim here is to optimize antimicrobial prescribing and use. And among the antimicrobial use metrics, which have been used since the 1970s by the WHO, include the DDD. The DDD is the defined daily dose, where you look at how much antimicrobials is being consumed by your patients over a period of time. And you also have DOT, your daily observed therapy, and standardized antimicrobial administration ratio. And each of these methods have their advantages and disadvantages. So they are slightly different, and they have their upsides and downfalls. And as we mentioned, we should review and compare these metrics and the implications from the antimicrobial stewardship view. Next. So come to structural measures. Next slide, please. So as we mentioned that they can be categorized mainly into three major groups. We have structural measures, process measures, and outcome measures. And of course, we have other metrics. And with regards to structural measures, they are used to assess the capacity of the hospital, the systems which are available in place, whether you have the formal antimicrobial stewardship committee available, maturity of your antimicrobial stewardship committee, at least 3 years, whether the hospital has a designated budget for your committee, whether you have the right personnel to champion the activities of your ASC. So do we have a physician? Do we have a pharmacist? Do we have the antimicrobial technician on board? And also, the metrics need to be reported to senior administration. So the senior administration of the hospital need to be aware of what activities are being done by the Antimicrobial Stewardship Committee. Then we have process metrics, and these include the main interventions which the committee deals with. So if it's a patient on antibiotics and is in renal failure, so is that patient being renal dosed? For a patient who is stable enough, are you switching from IV to oral? Are you de-escalating after getting your culture results? And are you stopping therapy when the prescribed time has passed? We also look at percentage order per protocol compared to what is in the guidelines. So here you're comparing what the physician is prescribing as to what has been prescribed in the guidelines. You look whether cultures have been collected before you start your antibiotics. Your intervention acceptance rate. So sometimes you might engage physicians and clinicians, and they might not accept your intervention. Average number of interventions per patient reviewed, and you're also looking at whether there are redundant therapy events, whether you are having, like for example, you can have dual anaerobic cover, patients being put on 2 antibiotics working in the same mechanism. Like one of the commonest is you find patients being put on meropenem together with flagyl, or patients being put on tazocin together with flagyl. And when meropenem covers your anaerobes as well as your tazocin. Percentage orders with regards to start and stop date. Then we have clinical outcomes, and some of these are usually not acceptable by the clinicians, because you'll be looking at your length of stay, your mortalities, and your readmission rates based on your patients with infections. Then we have other quality and safety metrics. So here you'll be looking at hang time, antibiotic hang time, from the time a patient has been diagnosed with, for example, septic shock, until the time the antibiotic has been hanged and is running on the patient. You're looking at adverse drug events, any patients reacting to antibiotics, any allergies, time to appropriate therapy, time to therapeutic concentrations, if you're doing vancomycin, if you're doing your other antibiotics which require therapeutic drug monitoring, time to oral conversion from when your patient becomes stable, rates of catheter-associated UTIs and central line-associated bloodstream infections, as well as mortality. We also have other metrics, and examples are financial metrics, and here you are comparing costs, and this is where most, the hospital administration is mostly interested in, and they'll be looking at antibiotic costs per patient per day, how much a patient is consuming. Like for example, how many patients are on meropenem in a day? How many doses are you giving? What's the cost of 1 vial? What's the cost of 1 full dose you're giving to a patient? Antibiotic costs per adjusted patient day. We have antibiotic costs per percentage to your total drug budget. How much is your entire budget compared to what your antibiotic budget is? And how much are you totally spending on your antibiotics? Wastage for specific drugs, how much are you find not all patients will be given a full dose, like especially for pediatrics. You find some of the vials you need to discard. You don't administer the entire dose. So how much are you wasting? how many drugs have gone, have expired, how many batches have gone bad, antibiotic costs per discharge. You're also looking at costs per length of stay, and as well as costs due to readmissions. So in conclusion, there are implications for antimicrobial stewardship programs with regards to these metrics. Your DDD and DOT and SAR are powerful antimicrobial use metrics, and since they've been used before and they've been approved by the WHO, and they can provide actionable insights on your antimicrobial stewardship efforts, though none of these metrics really describe the appropriateness of your antimicrobial use. So here we need to look at the methodologies which we are using, whether they are consistent, whether they're reproducible, and we need to measure progress, and we need to set goals. We don't need to measure and measure, and so that we have data for the purposes of auditors when they show up. Recommendations. ASP programs require validated and standardized metrics to demonstrate impact. And the most commonly used antimicrobial use metrics include the DDD, DOT, and DOT per 1,000 patient days. And although historically measuring costs is more important for purposes of justification towards your hospital administration, you also need to focus on the non-financial metrics. That includes the quality metrics and your clinical outcome metrics. So that's the end of my presentation. If you have any questions, I'd like to take them. Thank you very much.
Thank you very much, Dr. Jacob. That was a very illuminating talk, and by way of background, we had a talk on antimicrobial stewardship at last year's conference, and that was a very general overview. And what you have done is you have now delved into the specifics of how an antimicrobial stewardship program should be run based on your wide experience. So we can take a few questions. Dr. Jacob is also in a position where after he has done handling our questions, he will have to take our leave. So we can ask him a few questions. Ibrahim?
Yes, Dr. Ibrahim.
Thank you very much. I don't know.
Yes.
Thank you very much for that presentation. Mine is just a concern. These days when you do culture sensitivity, you've got automated machines which the moment you get a certain bacteria, automatically it tests against certain types of antibiotics. Yes. And sometimes the one you're using is not in that so-called panel. Yes. So I don't know how do you go around beating that. I don't know if there are any separate plates which can be used now to culture that. And is it relevant to you? This question relevant to you to answer?
So I think Dr. Majay is the appropriate person to answer that one. Though I can try and answer it, because these panels, they usually come from pharmaceutical companies, and they are standardized. So you don't have you won't get a perfect panel for the antibiotics which are present in your facility. And that is a major challenge. And I think we've communicated with them several times to inform them about that. But yeah, there's nothing forthcoming.
Sure. So let's look at a well-run laboratory that is doing its microbiology work according to commonly accepted standards and guidelines. We are moving towards automation in the field of microbiology. So when you grow a particular kind of organism, there already is a cassette of appropriate antibiotics for that organism, which will be run against that organism to give you a list of sensitivities and resistances. So for example, if you are growing an E. coli, and we don't use vancomycin in the treatment of E. coli, the E. coli cassette will not feature vancomycin. You can give lots of examples. Now, what happens is when you do it manually, and this often happens in laboratories that are not well run, that are not run according to standards, and when microbiology technicians have to, I'm not saying they willingly do it, but they have to put together whatever strips or discs they can lay their hands on, then you have these bizarre results that come out where, you know, they'll tell you it's an E. coli or a Klebsiella that is sensitive to vancomycin. And then the other danger that can happen is that when it's not done in a standardized fashion, the microbiology laboratory will run some second-line reserve antibiotics without running the primary antibiotics first. And so a clinician who is not well-versed in a good antibiotic choice might end up choosing antibiotics like ceftazidime avibactam in an E. coli isolate when a less potent antibiotic could have done the job, simply because ceftazidime avibactam appeared on that antibiogram. So there is a science and an art to choosing what antibiotics will go on your sensitivity panel. And I think the trend, nationally and internationally, is to standardize this so that when a lab technician isolates a particular bacterium, only the antibiotics that are appropriate for that isolate are run. Only an antibiotic that is appropriate for that species is actually run, and the inappropriate antibiotics are not run. So does that answer your question? All right, so. Yes, Zubair.
Assalamu alaikum. I think I should be in a much better position to answer that question because I am a microbiologist, at least in theory. But I would like to answer your query with one answer, AMS. So having an AMS committee is very crucial for all laboratories and hospitals because you have a multidisciplinary team. You have an IPC nurse, you have an ID physicians, who I think are very lacking in the country. You also have a microbiologist and a clinical pharmacist. So it's very important that you amalgamate all these teams, all these players in the same team, because one thing you realize again with these automation systems is, even in a place like Aga Khan, as privileged as we are, we don't have the luxury of using tailored panels or drug panels because they are very, very expensive, right? But even that being the case, you also have to know what drugs are available that you can test in your lab, but at the same time see what is available in the pharmacy to dispense as well. You can only do that when you come together as an AMS committee and sit down and harmonize all the black and white areas and have one standardized guideline. As for the guidelines, I don't know if most hospitals are aware, but we conform to guidelines known as CLSI, Clinical Laboratory Standards Institute, as well as UCAS. This is for the European standard guidelines. They basically dictate, or they're the Bible of microbiology. They dictate what panel goes for each drug, what panel is used for each organism, what panel is used for a particular site as well, because we have to keep in mind of pharmacokinetics and all those issues as well physiologically. So an AMS committee will answer all these questions or all these concerns. Thank you.
You satisfied? All right, thanks.
Wait, we still have questions.
Okay.
Here,
okay,
Dr. Yakub.
Sade.
Here. Yeah, I'm looking at the patient education.
Yes.
I'm not seeing it as one of the metrics, whereas it's very critical, particularly for outpatients.
Yeah.
And also the fact that they'll demand, I want an injection. If you don't give me an injection, I go to another provider.
Yeah.
So, and also compliance, treatment compliance, and the role of nurses. I mean, I'm just hearing about microbiologists and pharmacists. Thank you.
Sorry, my presentation was a bit biased because of my profession, but also because of the time allocated and the number of slides, I think I had to squeeze. But all that is inclusive of all the metrics which are included as part of your stewardship committee activities. Thank you.
Assalamu alaikum warahmatullahi
Wa alaikum
wabarakatuh.
salam.
Very good presentation. I don't know if I missed this,
Yeah.
but maybe could you clarify the difference between antimicrobial stewardship and pharmacovigilance?
All right. So pharmacovigilance, you're looking at all medicines here. You're looking at whether patients are reacting towards medicines, whether patients are actually achieving their clinical outcomes, the benefits, the clinical therapy. With regards to stewardship, it is solely towards, it's biased towards antimicrobials. And antimicrobial stewardship mostly focuses on optimal use of antibiotics, whether they're being given the right drug, the right dose, the right frequency, the right duration, the right route of administration. Yeah. So all efforts which focus towards appropriate use of antimicrobials, which will lead towards preventing the emergence of antimicrobial resistance. So that is antimicrobial stewardship. And stewardship is not only towards antimicrobials alone. We also have opioid stewardship. We have also other types of stewardship within the hospital setting. So antimicrobial stewardship is focused on antimicrobials alone. Thank you.
I think in the interests of having this session end on time, I think we'll end the questions for Dr. Jacob. And if anybody has a burning question, they can probably ask it offline. And thank you, Dr. Jacob,
Thank you very
for
much.
a very illuminating presentation. So we now come to the final talk of this segment of the program. It'll be delivered by Zubair Munshi. It's an overview of the interaction of medical microbiology and agricultural and ecological microbiology. The One Health approach, which I'm sure Zubair will tell us more about. He's a scientist with laboratory medicine as his background. He's a medical microbiologist with a focus on clinical bacteriology and antimicrobial resistance. He's been involved in collaborative projects at Aga Khan University Hospital involving international partners such as the Fleming Fund, German Research Fund, and MSF. He is a research scholar in matters revolving around staphylococci and an upcoming doctoral fellow on potentially the same. He has a keen interest on antimicrobial stewardship, surveillance, and capacity building for quality microbiology services throughout the country. Zubair, we are privileged to have you. Please come and take it away. Thank you.
Am I audible? All right. All protocols observed, respected dignitaries, delegates, and all in absentia. Assalamu alaikum wa rahmatullahi wa barakatuh. All right, so as to what Dr. Yaqub had alluded to earlier, the theme is antimicrobial resistance. So I'm actually thankful that one of the co-chairs is actually a specialist, so it should make my life easier. So over the next 15 minutes, what I intend to do is actually just give you a bit of an insight or a preamble, if you will, into this myth or into this term that we commonly call One Health, which apparently is not as common in the healthcare sector as most of us would think. So by a show of hands, how many of us have heard of the word One Health? Maybe in passing or at least through a show of hands. Not Aga Khan, guys, we trained you guys. Anyone else? All right, so a very small number. So the essence behind this presentation isn't to delve into the nitty-gritties, but it's really about creating awareness in this forum so that everyone knows that this is a pandemic or an impending doom for all of us. One Health. Exploring One Health in AMR, and what we'll also do, because this was also Dr. Sade's request a while back, was we'll try and put a focus on the Muslim community as well, because largely our consumers or our target audience at the end of the day is our Muslim patients. All right? Change. All right, thank you. So, One Health. You can see very nice fancy words. You can always put in a proposal if you want to get a grant, a collaborative multi-sectorial and transdisciplinary approach working at the local, regional, national, and global levels with the goal of achieving optimal health outcomes, recognizing that the interconnection between people, animals, plants, and the shared environment is important. So one thing I would like you to take away from this forum is in the world of infectious diseases, we can no longer separate human health away from animal health or environmental health, whether we like it or not. Because remember, bacteria are constantly reading books. And as Prof. Revati always says, bacteria don't read books. So what you might know about them yesterday may be very different from what you know about them in 10 years to come. That means you have to be constantly updating yourself. And they don't pick and choose who they want to infect. They could colonize a surface or an inanimate object like your phones. They could as well just colonize a human being or an animal as well. So what are the common One Health issues? One Health is a very broad term, although we'll be focusing mainly on antimicrobial resistance, but essentially it looks at all diseases or issues that plague all the three facets of One Health. That is your environment, your humans, and your animals. So we have antimicrobial resistant germs, your bacteria, to which Dr. Maj has given a few examples. We have vector-borne diseases, and this is very important. I don't know if you guys noticed, especially for the guys from Nairobi, around February or March, there was a huge influx of mosquitoes out of nowhere, all of a sudden. Anyone noticed? Unasha doom, uneka coil, nothing happens. Hata unajipaka mosquito, nothing happens. Only to find out from an internal memo by Kammp that there was a new species of Anopheles stephensi. This is a new species as part of the Anopheles gambiae complex, previously unknown to the African region, and it was very prevalent in Middle East, Southern Asia, and the Mediterranean region. It now became a new vector for us, and that is why you saw this influx of mosquitoes. And the biggest challenge with that is this stephensi species is a better vector for the rapid transmission of malaria. Now the question is, where did they come from? Why did they come to Kenya all of a sudden? Because there are also a few isolated cases from East Africa, Djibouti, Uganda, and so on and so forth. The biggest problem, or the biggest cause, at least in theory, was climate change. Climate change, as you will come to see, is one of the biggest causes of infectious disease movement or migratory patterns. Coming to disease in food animals, we still have a cholera outbreak in the country, in case you're not aware. The data or the statistics might be slightly underestimated. That's for contamination of water. Diseases in food animals, remember at the same time, the animals that we're farming serve as food animals. And in this world and age of consumerism, we're consuming a huge amount of meat and dairy products. And all these meat and dairy products, before they come to your butchery or before they are processed, they all have at least a few antibiotics because of the intensive farming processes. So you are more or less ingesting in one or the other antibiotics, or at least byproducts of antibiotics. Now, the question is, why are we talking about One Health now? Especially in the world of modern medicine, it's quite unfortunate that we have to hear about One Health a few decades later. Someone would argue we're a bit late. This is the answer. So in this modern age of globalization, we have a lot of people living together, a lot of the community, the community density is very high. For example, you can just see the cluster here. If someone wants to do a cluster analysis, you'll see it's a very condensed space with very little space. Changes in climate and land use. Again, someone will argue, in our environment, sisi shida yetu ni patients, si wanyama. But remember, climate is the same reason, or climate change at least is the same reason why we saw an Ebola outbreak in 2014. Where was this? At Uganda. 2014, where did we have one of the biggest outbreaks? Sierra Leone, thank you so much. That was where case 0 was suspected. And the main cause of this Ebola outbreak was from a fruit bat that was not previously known to be within the West African region. So these bats were also exhibiting migratory patterns. So when they moved from one place to another, they also introduced their diseases that were previously unknown to that place. Another issue with climate change is, again, with dengue and chikungunya. So as far as northeastern and the coastal regions are concerned, I wouldn't say it's very prevalent, but there are quite a number of cases of dengue and chikungunya, right? We have a lot of circulating genotypes of dengue 1, 2, and 3, as well as chikungunya 1, 2, and 4, usually in coast. But for some reason or the other, they've been documenting cases within the sub-Mediterranean region, towards Tunisia, Egypt, areas that border the Mediterranean Sea, all because these mosquitoes are moving as a result of climate change. So you see, infectious diseases is moving. So I am not an advocate of the term that this infectious disease is prevalent in this area. In this time and age of globalization, anything can spread anywhere, right? That's where global and trade comes in. The other reason why One Health is important, and again, animals are not just for eating, right? They're also companion animals. For those of you who are involved in animal welfare, you will also notice that a lot of us tend to be in very close contact with animals. And in that process, we end up being subjected to the disease or being exposed. So more than half of all infections that people can get are zoonotic, and they can spread between animals and people. Case in point, salmonella, salmonellosis. We also have other zoonosis like anthrax as well, for those of you who eat meat contaminated with Bacillus anthracis spores. Now, just to cement this idea further, because as a microbiologist, I'm still in the lab, and the idea that we're pushing forward is evidence-based medicine. So it's part of my mandate to also provide with you evidence so that you know I'm not just talking rubbish, right? So what you're seeing here is staphylococcal work. This is a bit of molecular biology. What you can see here are the different sequence types with different cassette elements of MRSA. So previously, a few years back, you would find MRSAs of particular clones reserved to the US. For example, if we look at, can you guys see the pointer? All right. So if we look at USA 300, this is an epidemic strain that is commonly associated with community-acquired MRSA that also harbors the pavin leukocidin gene. The point of origin used to be there in the US and Canada, sequence type 8, cassette element 4. But if you look at the same strain, you can find it in Africa, Europe, Asia, New Zealand, meaning the bugs are spreading, right? At least if not through people, then through vessels or through animals, or there are other conduits for spreading. Now, the reason I put this slide, it may seem a bit cliche, but you'd be surprised to know that there are a lot of healthcare workers who are very reluctant to believe that antimicrobial resistance is a thing. It's a bit of ignorance. I don't understand why. Is it through lack of education or for some reason? But it is there. It is very disconcerting to know that someone believes that antimicrobial resistance is not a thing. It's science fiction, apparently. Now, coming to the crux of the matter of why we're here today, what I intend to do is actually show you how the use of antibiotics across all these three facets, animals, humans, and the environment, ultimately still comes to bite us back, because ultimately we're the ones who will be affected. So this is just a transmission pathway that shows us how we consume antibiotics and how they end up being spread to the environment. So let's start with our fellow. Zubair has been admitted, he's sick, he's gone to the hospital, he's been given antibiotics. He'll ingest those antibiotics, then through excretion, those antibiotics, or at least the byproducts of those antibiotics, will be excreted through the sewage or waterways. The same wastewater treatment plants we use here, for example, I think there's one in Shanzu, Kariobangi, and so on and so forth, are treating this water for all these contaminants, but they can't clear everything. So even the water that you drink or the water that we use for normal things in the house still has some element of antibiotics. The same antibiotics, which are from these wastewater treatment plants, will be taken up by the agricultural industry for farming. If not for the animals for use, but for agriculture again. So the water that's being used to irrigate the farms or the plants as well are still taking up antibiotics. And thereby, in the process, the bacteria that are on those plants will be subjected to selective antibiotic pressure and have to develop resistance to that antibiotic. Then you, again, the consumer, you'll have your kuku, you'll have your nyama choma, again, ingesting that same meat product that was ingested, that was from an animal that had taken water that had antibiotics. Or if not the meat, then at least the plant products. Now, we'll focus on them one by one. The time, please. 5 minutes left. All right, I have to move quickly. So with regard to human health, we know the importance of antibiotics. They're not just used for treating infectious diseases. They're used as a prophylactic measure when you're dealing with immunosuppressed patients or patients undergoing chemotherapy or during elective surgery. Again, we've heard the term emergent MR limits treatment options in infections, but why is this a problem? By 2050, I think his name was Charles, he was one of the economists from 2014 during the time of James Cameron. They did an analysis or situation analysis. They said that as per 2050, or as of 2050, all antibiotics should be almost globally virtually ineffective, right? And if you look at the map here, as always, Africa and Asia, by being virtue of LMIC, will be bearing the brunt of mortalities associated with infectious diseases. So we're looking at global mortality rates of 10 million per year, with Africa and Asia taking up 8 million out of 10 million in a year, as per 2050. Now, looking at this is one of our papers we've put up there, it's on our posters. This was a bit of sequence analysis, molecular work on some of the MRSAs that we isolated over an 11-year period. But what I want to try and show you guys is the spectral diversity of the different mutations this MRSA has. You have an MRSA that's resistant to a beta-lactam aminoglycoside and so on and so forth. But at the same time, you also have multi-drug resistance being exhibited. So you could find an MRSA that is resistant to maybe just one non-beta-lactam class, and you could find another one that's resistant to up to 6 non-beta-lactam classes. So it is an actual threat. When it comes to the animals, where antibiotics are used is for infection treatment for animals that have subclinical mastitis or clinical mastitis, for metaphylaxis. So metaphylaxis is a practice in farming where if one of the animals has an infection, then the farmers will give the other animals that don't have an infection this antibiotic. You could almost call it like a prophylaxis, but they say it's just kujikinga. And again, the problem with antibiotics is they're used in farming for commercial products or for commercial use. Remember, we're in a world of consumerism, so low dose antibiotic growth promotion. For poultry and swines, you'd be surprised to find that for pig farming, up to 10 weeks during the breeding process, during the first 10 weeks of life, all these pigs are pumped with at least 90% of the commonly available antibiotics we have. During the first 10 weeks, 90% of the antibiotics. We don't know that could be the same case for our beef, for our mutton, and so on and so forth. Now, this is a study we did in Germany. I was in Germany last year doing a bit of phage therapy. So phage work, bacteriophages or viruses that infect bacteria. So what we sought to find out was we found one of these isolates, Staphylococcus aureus, that harbors what you call daptomycin resistance cluster. So it's a gene for daptomycin resistance that is found in a Staphylococcus aureus strain. So we sought to investigate whether that daptomycin resistance cluster can move from one bacterial species to the other, basically to see if it's found on a mobile genetic element. And if that's the case, that means it can be easily transmitted from animals and to humans. And what's the consequence of that? Daptomycin is a second-line lipopeptide or an anti-staphylococcal agent. So you can imagine having resistance to a second-line antibiotic agent. That's a problem for us. This is just some of our phage work. This is our transfection. Now, is there evidence for cross-transmission for AMR? For antibiotics, colistin is commonly used in farming for poultry and pigs, and one of the organisms that are commonly develop resistance to colistin is E. coli and Pseudomonas aeruginosa. We have our fluoroquinolones, the same case, and the organism or the culprit is Campylobacter jejuni. So this is a paper we published focusing on the different antibiotics and staphylococci species that are commonly found in animals that have subclinical mastitis. And the takeaway message from this is that they all exhibited high amounts of resistance to these antibiotics that we also share. Coming to the environment, water plays a crucial role in antimicrobial resistance. Someone would ask, given the cycle I've told you, someone would ask, how is this important? This is what happened 2 days ago. I never thought I'd have to come to Mombasa in December wearing a jacket. It was very strange, but a few lives were lost over here. And now the biggest problem with this is when we don't have proper drainage systems and all, we have flooding, you end up unearthing extra bacterial or antimicrobial resistance to which people get subjected to. Then they come back to the same hospital where you are treating them. So in essence, you might be treating this patient, but they'll go back and because of this societal, social determinants, they come back again with the same recurrent infection. So you are really managing the symptom and not the disease. It comes back. Just to show us, this is just an impact. I'll slightly take into your time 2 minutes, if that's all right.
Then in that case, we won't entertain questions. Yeah,
I'll
a couple
be very
of minutes
quick,
and
yeah.
no questions.
I'll be very quick. All right. So this is just a paper to show us the impact of flooding. So what they did was they assessed the soil 3 to 5 months after flooding. So you can see over here, we have high levels of tetracycline, Tet A, Tet B, Tet C, Tet E, Tet G, 3 to 5 months after an area was flooded. So that area is still exposed to these antibiotics. So again, it tells us we need to work on our sanitation, public health, public sanitation, and so on and so forth. All right? Now, coming to the Muslim community, because this is very important, they are our target audience at the end of the day. Nomadic pastoralists have not been known to be frontiers of antimicrobial resistance. More often than not, whenever we talk about data, not the northern regions of Kenya or northeastern tend to be neglected, right? But at the same time, remember these are nomads and their pastoralist movements end up affecting the movement of zoonosis or patterns of diseases from one place to the other, right? Now, this is just to show you some of the resistance genes that have been found in this nomadic livestock. For example, cattle. These are some colleagues of mine that did some work in northern Kenya. They were looking at extended spectrum beta-lactamases in camels. So you can find high levels of resistance, especially in your cefotaxime, cefepime, and all. Basically, they exhibit expected spectrum beta-lactamase enzymes because they're using antibiotics to treat their camels, if not judicious use of antibiotics. Coming to dogs as well, because nomads also use dogs for protection purposes, what they sought to compare was the types of E. coli that they were retrieving from dogs as well as the nomads themselves, only for them to find out, if you look at the red circle there on the top, that they found similar clusters of E. coli isolates, so basically E. coli isolates of the same type retrieved from the dog and retrieved from the same human who was in contact with them. And they all exhibited the same pattern of resistance against a cephalosporin as well as a quinolone resistance. Now, the question is, what are we doing as a country and where are we as a country? So being part of Aga Khan, we are part of the Fleming Fund Initiative. And one of the core mandates of Fleming Fund Initiative is improved antimicrobial stewardship and diagnostic stewardship. So we are looking at 7 sentinel sites, Jaramogi, COSGEN, and so on and so forth. And our core mandate is to just try and improve capacity building for antimicrobial stewardship and diagnostic stewardship. So again, the reason why I've highlighted this area is if you look at all the 6 sentinel sites, northeastern and northern Kenya tend to be neglected areas. So the data there is very lacking. And we could be seeing a completely different spectrum as far as antimicrobial resistance is concerned. Now, what are we doing as a country? We have a national action plan that was developed by NASIC, National Antimicrobial Stewardship Interagency Committee. This is available in the WHO website. It basically talks about the One Health approach and how to mitigate it. So as far as our strategies are concerned, the usual things, public awareness and education, surveillance monitoring, infection prevention and control. We're all aware of the WASH programs by WHO because hand hygiene is very essential. Appropriate use of antimicrobial therapy. Let's stray away from empiric treatment and start de-escalating. Let's move towards evidence-based medicine. And R&D is also important. So coming to the end, what would I recommend our take-home messages? Aside from these, we need to, for the physicians here, or at least for the MOs here, we need more of you to move into infectious disease specialty. We also need more antimicrobial stewardship committees. At the same time, we need improved microbiology lab capacity, if not at the human level, then the animal level, at least for surveillance, be it genotypic or phenotypic. And we need to explore other avenues apart from antibiotics. Is it phage therapy? Is it traditional, complementary, and alternative medicine? And in conclusion, One Health is a serious crisis that has to be taken seriously. Because we live in a world of colliding epidemics, you can't single out infectious diseases alone and single out non-communicable disease. More often than not these days, communicable and non-communicable diseases go along together. So One Health approach is very important to look at as well. So thank you, ladies and gentlemen. I'll think of each and into your time.
Thank you, Zubair. That was a very extensive topic. It would normally have provoked a lot of questions and discussion, but we are running 45 minutes late, so I'm afraid we will have to move on. Thanks very much.
Maybe 5 minutes in case anyone else
No, we're running 45 minutes late, so I'm sorry.
That's all right.
Are we moving on to the next item?
We won't take questions. However, our brother is still around and all the presenters will be here. Should you have any questions, please do not hesitate to approach them. Okay? Thank you.
Okay, so who's Ajabe?
I've sent to the phone.
You have others speak on your side?
No, we're done.
Okay. So, Dr. Abdullah Bajabir, please come ahead to prepare for the panel. I have to recognize a few brothers and a sister. As we were worried on Friday, we came to prepare this venue. As we came, so on Friday, we came to prepare this place. It was raining heavily. We were very worried on how will people make it from town to this place, plus this road, okay? Alhamdulillah, an idea of a bus came, which was embraced very well. But imagine, it is less than 20 kilometers from here to town. kindly the brothers and sisters from Mandera stand up. I would openly want to recognize the effort that they've traveled from Wednesday morning, despite all the rain, the roads, and came to us. Isaac Gulo, Rukia Hassan, Hassan Kala, Muhammad Hassan, and Asha Hussein. So we appreciate you taking 3 days to come to us. In case you can make it any easier, please let us know. But also it makes us more shameful for the people who are just 20 kilometers away to say, should I come? It's rainy. So you have really humbled us with all your efforts, and Jazakumullah khair. Thank you. Okay, Dr. Abdallah Bajabir, please take over and
Assalamu alaikum wa rahmatullahi wa barakatuh. We're moving on to the next panel discussion. One of the reasons we had this panel is because it's something that is touching on all of us. We wanted to see the interplay between healthcare workers. What are the contributions, what is the role, and what is the challenges in the Islamic perspective, and how is the interplay with the Islamic teachings. And that's why we have our scholars with us to see what is their role also in terms of health and what is our role in our religion. So I'll start introducing our panelists. And you know, our panel, mashallah, is more or less like a box of chocolates. Yeah? You never know what you might find. But let's open this box and see what we have. The first on the panel is an artist. Yes, we have an artist. And I'll explain why. He has a degree in Sharia from Islamic University of Medina, Kingdom of Saudi Arabia. He has a Master of Arts. That's why he's an artist, yeah? Has a Master of Arts Islamic Studies from Pwani University, Kenya. He has a Diploma in Education Management from Kenya Education Management Institute. He is the Deputy Principal of Sheikh Khalifa bin Zayed Al Nahyan Secondary School, which I was in, and I'm proud to have him here. He's a member of the ethics community of Aga Khan Hospital, Mombasa, and is a member of Majlis Ulama Kenya and Council of Ahlul Sunnah wal Jama'ah. He played a very pivotal role during the COVID-19 period as the Mombasa chair, which most of you are aware. He's the Khatib of Masjid Dibran in Mtwapa and Masjid Sheikh Khalifa. And as you all know, recently he launched his book as the published author of the book entitled Reviving Islam. Kindly welcome our Ustad Sheikh Rishad Rajab Ramadan. The second panelist is a very close ally and one of our officials. He's someone trained on social innovation and system change at University of Cape Town. He's trained in leading high-performing healthcare organizations at Strathmore University, Strategic Leadership Development Program at Kenya School of Government, Information, Education and Communication in Health at Okinawa International Center, Japan, in Executive Hospital Management at USIU, Nairobi. He's a long-standing advocate for community health and ardent primary healthcare practitioner. He's a public health officer. He's the head of primary care at the Ministry of Health, and now the Deputy DMS, Director of Medical Services. He's a committee member of Kammp Nairobi branch, and he was one of the founders of National Muslim COVID Response Committee when we had the challenge of COVID. Dr. Salim Hussein. And last but not least, we have a brother and close friend of Kammp from diaspora, who is joining us online. He's a council member of British Islamic Medical Association. He's director of Kammp Lifesavers, Female Lifesavers Project. He's a founding member, Faculty of Medical Leadership and Management, who is a family physician by profession, Dr. Muhammad Wajid Akhtar from the UK. So our moral guide is usually our religion. And I would open by saying that Imam Shafi clearly stated that he doesn't know of any other education that comes secondary to the education or the knowledge of deen than the knowledge of medicine. So all of you seated here that have a role in healthcare, you should know that your stand in the community is held very high. And with that, I would go to our Sheikh, who has been a very active partner in Kammp, Sheikh Rishad. Bearing this in mind, what is the status of healthcare workers in Islam or health, and what role do you think they can play in dawah or in propagating Islam?
Bismillah, wassalatu wassalamu ala rasulillahi wa ba'd. Assalamu alaikum wa rahmatullahi wa barakatuh. Rasul sallallahu alayhi wa sallam, in a hadith that is found in Bukhari, Muslim, and even Ibn Majah, has advocated the Muslims when they are sick to actually go seek for solutions. Much as in Islam, when we are sick, we have two choices. One of the choices is to pray to Allah subhanahu wa ta'ala for shifa, and the other choice is to actually go seek for medical help. When we say go seek for medical help, it means going to seek help from a medical practitioner. So a medical practitioner in this instance stands at a pivotal role. You are very crucial in the Islamic society to the extent that even when in the times of war, you are in the front line. You are the most significant person. Today we mention Rufaida al-Aslami, radiyallahu anha. She's actually the first nurse long before some Nightingale lady. She needs to be studied because she was the leading nurse during the battles, and especially the Battle of Uhud. Umar radiallahu anhu, after being stabbed, they called a doctor at that time, a medicine man, who when Umar took a sip of milk and it came out from below his navel, he said Umar has only 3 days, and the political thing started, istakhlif or lam yastakhlif, should he choose a successor or not. Abu Bakr as-Siddiq, when he took a shower in a cold day, he decided to take a bath on a cold day, and he developed a fever in 3 days, and then he passed away. The medics came and of that time. So Islam really reveres doctors. You have a pivotal role to play in the society, and to some very great extent, you're even more respected than the Muslim scholars. But maybe sometimes we tend to forget about that. You really need to understand when Dr. Hooker was saying it is a must that you feel it within yourselves to do the due diligence. It's not a must, it's a wajib. The minute you went to study medicine, you have to understand one thing. When you look at a patient, it is two things. It is you, the decision that you're going to make, how it will affect the health and life of that person in front of you. And remember, Allah subhanahu wa ta'ala is monitoring and watching over you. You see, you might make decisions that were not carried out due to due diligence. We won't know. No one is going to know. But Allah subhanahu wa ta'ala is monitoring everything that you do. because Allah has Raqib and Atid who are following you up in everything that you do. So when he said it's a must, it's just not a must. May Allah bless him for saying those words. It's about you and Allah subhanahu wa ta'ala in front of that patient. And what are you going to tell Allah subhanahu wa ta'ala in terms of the diagnosis that you need? This is how it is. So collectively, you people have a duty in front of Allah subhanahu wa ta'ala. And Imam Shafi'i, to say what he said, لا يخلو القرية عن عالمين عالم في الفقه وعالم في الطب, says the two most significant scholars in a village are two. عالم في الفقه, the scholar that is knowledgeable in jurisprudence, and عالم في الطب, the scholar that is knowledgeable in طب, which is medicine. They're the two most important people. لا يخلو, it should not, it can miss everybody else, but not these two. Why? One gives us shifa al-ruhi, one gives us the medicine for ar-ruh, that is the jurist, and one gives us shifa al-badani, the medicine for our physical health.
Shukran, Jazakallah khair, Sheikh Rishad. You've heard it from the Sheikh. One of the challenges usually is that we tend to, even with our patients, we tend to listen to the scholar, which is right. But you've heard it from him, I think it would be taken better than what I said. And coming back to the same point of the importance that Muslim healthcare workers have, I move to Dr. Salim, who has been guiding us time and again on how Muslims can take pivotal roles, both in managerial positions and in Kammp, and what can Kammp do in terms of driving the agenda forward. Maybe Dr. Salim, just give us a rough estimate from your years of experience. How has the health workforce, especially with the Muslim healthcare workers, how has it been? Just maybe just a ballpark figure, and what do you think these numbers mean, or what could they have an impact on?
Bismillahir Rahmanir Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Actually, in terms of numbers, for example, at the Ministry of Health, the senior management currently we are actually about at 9%. Out of the 45 positions that are there, we have only about 9 Muslims actually at senior management. In terms of the staff, we are actually about 7%. Out of almost the 3,000, we are about 250. In terms of the specialties out of the Ministry of Health, actually I was just checking, we have registered specialists in Kenya who are 3,103. We have 320 specialists in Kenya. So if you are a specialist and you have not registered with the Kenya Medical Dentists and Practitioners Council, please do so. We've just gone, checked all the data. We are 320 Muslim out of the 3,103. In terms of the licensed medical officers in Kenya, we have around 10,891. The unlicensed, unfortunately, we could also be having some Muslim who are unlicensed. There are about 5,412. We have a few who have been retired, but still they have been retained in the same, and some who already had been registered in the council, but deceased are about 260. So I think in terms of numbers, especially at the policy level, we are not many. But I think what is important is what the influence, what we are doing at that level, especially incorporating our Muslim brothers in different organizations, institutions, whenever we can, and especially when policy directions are being made or a heavy decision. For example, very recently, when we are coming up with the primary healthcare networks, I think we made sure that the Muslim organization, Muslim brothers are incorporated, because in the current structure, as we are implementing UHC, the primary healthcare networks, there will be 315 in the country, and in all of them, we expect that the private, public, and faith-based will be involved. Unfortunately, faith-based most of the time at our higher level is actually meant to be the Christian and the other religions. So it will be very important that this position there will be primary healthcare networks, committees, which a faith-based organization should be incorporated. And I think it will be very important that for us as Muslim, we try and fit into those areas, especially the counties where we have Muslim. We are grateful that in terms of currently the students, the number of health workers that are coming, actually in terms of Muslim, it has increased. We are glad on the same. We are also very grateful and happy to see that in most of academia institution, we have Muslim professionals at a high level. We can do better, but we have all the specialties that our Muslims have covered. In terms of the implementation at the county level, I think as the Muslim counties is where we can say we have a higher number. Otherwise, the rest we have at less, in some counties, less than 5 to 10%. Thank you.
Mashallah. Shukran, Dr. Salim. And we appreciate the efforts and stressing out. We've had this conversation before on the roles that we can play as healthcare workers. And I remember you mentioned that Kammp has so much opportunity and power that if you look at every field, we have almost a leader in that field, whether it's on organizational level, clinical, non-clinical. For example, KMA in itself, COGS, we've had leaders like our past immediate chair, Dr. Ramadan Marjan, seated here. Kenya Renal Association, we've had a chair, our president, Dr. Tahir. We have the top neurosurgeons, almost every field, in research, everything. So we need to harness this power. And this is what we are doing locally, but we don't know outside. And that's why yesterday we were talking about FEMA and what they've accomplished. So that's why we brought our brother all the way from UK to hear from them, maybe from your experience as a council member and an official of British Islamic Medical Association. What have been some of the achievements and challenges you have faced in your country? It's muted, I think you. Now we can hear you. Wa alaikum salam.
There were Muslim doctors and healthcare workers and nurses and professors in doctors from one end of the UK and the other end. We have old and young, we have Arab and African and Asian, we have doctors and nurses all in one group. And when we did that, then we said, right, now let's show what unity means. One example, which you guys took part in, mashallah, and actually, I have to say here about the Kammp Lifesavers team. I was in touch with 24, 25 teams from across the world, and the most organized, I'm not saying this because I'm in your meeting, I'm in your meeting because this is the truth. The most organized team was Kammp. This is urgent, this is an emergency, let's work together and let's deliver results in masjids, let's train people. I'm sure there were many people taking part, they never even heard the Kammp for the first time, they never worked with different people for the first time. But because they did that, they saw, oh, subhanAllah, look at what unity looks like. We all know this, right? Muslims, you pray, in a little while, you'll pray your Maghrib prayer. You pray Maghrib prayer by yourself. Or you pray in the masjid. If you pray by yourself, you read 3 rak'ahs, in the masjid you read 3 rak'ahs, read the same surah. In the masjid you get more than 20 times the reward. Why? What did you do differently than most? Because it's everyone around you. Barakah really is a multiplier effect. It has a multiplier effect. So my brothers and sisters, we've instituted in the last year something that Lifesavers program in CPR and masjids. We have a program called ACE. The medical students, pharmacy students, dental students, when they graduate, in the university, they teach you how to, they teach you medicine, they don't teach you how to be a doctor. They don't teach you how to run a ward round. They don't teach you how to do better in your career, how to make the specialists happy. So we have a webinar, and when everyone finishes, even when they finish their degree, before they start the job, we do this webinar, it's free. In the last 20 minutes, we tell them, don't just be another Muslim who is in the top 1% of society because you're a healthcare worker. You need to do something for your You need to work hard for your We talk about cancer screening, we talk about medical aid, we're standing up for Muslim rights. Because here in the UK, even if you say one word for Palestine, they will come down here with a ton of bricks. So, because alhamdulillah, we've got 7,000 members now, we wrote in advance to the health leaders and said that if you target a Muslim because of being pro-Palestine, we are watching you, and this will be a very negative thing to do. And we want you to speak with us before you attack anyone. You should not attack anyone that. Okay, so I've gone on and on, so I will stop.
Inshallah, we'll come back. I know how, mashallah, passionate you are regarding connecting the community and the healthcare workers.
Coming back to the point of the healthcare workers and the positions or the role they have, we know that they're very important, but with the current constraint of majority of our medical officers being, some of them are actually here, the constraint of getting work or employment in the country, even though the workforce is really constrained, we are not yet where we're supposed to be, but with that current problem, as Sirkal, tell us, Dr. Salim, what are some of the avenues? I know the avenue you are supposed to give us, or the ministry is supposed to give us, is just employment, because we need that workforce together. But on your personal level, what do you think are the avenues that these professionals can take?
Thank you very much. I think, as you are saying, more and more of our colleagues in the health field are being trained, and the government is not employing. Despite that, we still have a gap according to the WHO standards. Actually, currently, our ratio for health workers to our population is about 1.48 per 1,000. Ideally, it should be about 4.5. So it's less than even half of what we had expected. But the government, due to several issues, is not employing, including physical difficulties. So I think, for me, this is an avenue where we need to come together. We need to sit. We need to think outside the normal laws for us to be employed by the government. So we need to start thinking of a health management organization where us as Muslim, we can manage our own health workforce. We can incorporate them somewhere before they are engaged. We can have a better bargaining power for them if they were to be recruited or they were to work for other organizations. We know currently, because of this influx of people who do not have work, some of them are actually working under very constrained situation, even the payment, because the facilities, for example, where they're going to do their locums, they know they're desperate and they can pay them the minimum. So I think one of the things that I'm happy that Kammp is doing is the issue of starting their own facilities. I think that is the one way to go. I think the other is to bring these young health workers together, give them trainings where they're not trained. For example, what FEMA is talking about, how to manage a ward round, how to manage work, how to be a manager. But more importantly, I think it's for us as Muslims now to think, how can we put them somewhere as they're waiting for some for employment, if that is what we're waiting for. But more importantly, why can't we just look for that employment ourselves as a Muslim organization? So we can actually have our facilities, we can start running other facilities, we can actually tell them we have the human resource, we can run the facilities for them, of course, at a better bargaining power. The other thing, I think we also need to look at the emerging issues, especially for me, the issue of AI, digital. Our training institutions, are we reorienting the training to face the new upcoming issues that we need to deal with? Otherwise, some of these might render some of us irrelevant. Thank you.
Shukran, Dr. Salim, for that point. And one of the challenges we've faced, actually, as healthcare workers, by the way, Sister Romana was supposed to be here with us, who has worked for several years as a matron in various facilities, but due to an emergency, she wasn't able to make. So this panel was not meant to be men only, so don't bring the 2/3 gender rule. So one of the challenges we face is breaking into the communities. And the challenges faced is that most of the people, based on what we tell them, that goes against what they understand as the Islamic teachings. Maybe from your point, Sheikh Rishad, you've played a very pivotal role in addressing the stigma during COVID time. What do you think, or how can the scholars, have an interplay with the healthcare workers in addressing these issues, or what can you advise us in terms of this challenge?
Bismillah, salatu salam ala rasulillah. I think doctors and Muslim scholars need to work together. At the moment, I think it's the Muslim scholars who really beat up at the doctors in terms of the cost of medicine, and that Muslims have to go all the way to India to be treated by non-Muslims and etc. So it's because I think there's a gap between us. We need an understanding. Maybe I'm only one or among the few who work with you, but we need more of us in the circle, so that they understand the intrigues, they understand everything else. So we need maybe meetings just between us and you, so that you remember in COVID, we had doctors going into mosques. Dr. Ashraf, Dr. Marjan played a pivotal role in that. And that is what actually made people understand what we are facing, and how that is what brought the understanding. So when we work together, we can actually bridge the gap. But there's a very big gap right now, to be very honest. The Muslim scholars look at doctors as people that just want to get rich out of calamities of the fellow Muslims, and that's not true. When you're seated here in this conference and You see you know the cost of medicine, you know the cost of the so many procedures that are there. This is not something that a doctor wants, but you can see how decisions sometimes are made because when something costs so much that the doctor shies away even from, you know, bringing it up because people think you're overcutting it or something like that. So I think we really need to sit and work together, make our fellow Muslim scholars understand what is, because that is what made, I think, Nairobi, Mombasa achieve the success that we achieved, is because we brought the Muslim scholars and the doctors together and they had an understanding. The doctors spoke about COVID. They understood. And that is why in the end of the day, we accepted people being buried in body bags, and there was no much pressure about it. Yes, there was resistance, but people understood to the extent that when somebody died, they didn't even want to, you know, to do anything until the COVID Muslim team came. So if we can work together the way we worked during COVID, I think that is the way to go.
You mentioned the COVID time, which reminds me of the input that BIMA actually had. Most of our protocols, I remember we were in constant communication with Dr. Wajid and team on what protocols we could use during BIMA, and I keep saying they are our role models. Even what they're doing now in terms of Islamizing medicine, they have a project called History of Islamic Medicine that changes everything we've been thinking, that this was invented by so-and-so, this was, but goes years back to our scholars, you know, Razes, Ibn Sina, and all that. And it's actually a project to try and change this narrative that this was started by so-and-so a few years ago, while actually it was explained in details by some of these scholars. And brings me back to Dr. Wajid, maybe a final comment on what made you start the Lifesavers program. I know it's CPR, but you had another intention in mind. And what is this, and what do you think it's important?
I think with the Lifesavers and COVID, very similar intention. You need to be grassroots, as the chef just said. You know, the doctors, we're the elite of society, whether we like it or not, because we usually get paid better, and we're more educated than most of the Muslim community. So this means we have two choices. We can either save ourselves, and then our community will hate us, and we will hate our community, or we can strive to use this as an extra responsibility to serve the community. And the idea behind Lifesaver is that it's very obvious that we can unite together and we can achieve much more. Just for some small knowledge that we have in our head, every one of you in this room. When I did the first Lifesaver in Quickbook Mosque, I asked if they had any questions. I'm not, I'm very nice to him. He said, you told me this last year, maybe my daughter will like it. This is the way our whole community feels when it comes to community, when it comes to healthcare. We should take the best from the past, which is we should be educating our community, and we should be helping them. Because the strongest of community means we are stronger as well. And my advice to Kammp is make sure that you get into your community on the grassroots. I'll give you an example. With COVID is a very good example. The professors, the Western think tanks, they were releasing 10-page PDFs about COVID, about communicable diseases, statistics, studies. They were going on the 9 o'clock news. We want to tell you, everyone, that it's very important to follow. Nobody was listening. And what were the anti-vaxxers doing? The anti-vaxxers, they were literally just, hey everyone, don't take the vaccine. You know, if you take the vaccine, your eyes fall out, and then you vomit your nose. This is horrible. Stand on WhatsApp. Everyone was listening to the anti-vaxxer because it's coming across as authentic, and they're reaching the people where they are. Where are the people? They're on WhatsApp. Your grandfather is on WhatsApp, and your grandchild is on WhatsApp. The rich and the poor, they're all on WhatsApp. I'm saying to you, not saying just do WhatsApp, or I think that's important. What I'm saying is reach out to the grassroots. This is the most important thing. Everything else you do is important. Policy is important. Strategic work is important. Supporting each other is important. But grassroots activity, you're in the hearts of the people. Every Muslim and non-Muslim in Kenya should know the name of Kammp. It should be for them like Tesla, Apple, IBM. You know, it should be something that they aspire to. That they say, don't just be a healthcare worker, join Kammp. Why? Because they came into our village, they came into our community, they taught us about X, they did Y, they did Z. Nobody else touched us. And yes, this means you have to do multiple activities. When we were in COVID, we were sending, many messages. None of them were 3-page PDFs, very short, very simple, forwarded. Most of them, they didn't reach anyone, but a few, they really hit a nerve and they went viral. So, inshallah, this advice, unite together, then inspire each other, inshallah, to serve the community. That means go to the grassroots. Everything else is important, but the grassroots is what gives you the strength of the community. And this can change people's perception of Islam. This can change your education levels in the community. This can change your political power. If Kenya as a country sees that the Muslims, they really love this together, this revolution will spread across Africa the way that you're doing it. We don't need to leave it to the West to teach us how to do public health. We have, as Dr. Abdullah was just saying, we have a much greater legacy in the past, much greater legacy in the future.
Shukran, Dr. Wajid, for your input. As I said, they are a Muslim, or rather we can call them a non-Muslim country that has done so much despite, the constant, constraint that they have, and the pressure that they have. And inshallah, we aspire to get to those levels, but it has come from the Queensland that not just us, we kept telling you since yesterday, joining the membership, we can do a lot together. Just a small example, when we went to Malaysia for the conference, most of the studies we saw, most of the studies for that specific conference or the presentations were based on Islamic issues. Because the idea is that all of us here belong to professional organizations. You have pediatric association, orthopedic, whatever, you name it. We can attend these conferences and have scientific talks and have any studies there. But these guys were doing studies on tahniq. They were doing studies on spiritual harm or something like that. Is there such a thing as spiritual harm? They're doing issues, related to our health. When you talk to someone based on scientific studies and prove that, this is what tahniq does, this is what this does, they tend to take it more than when you just present data. So just final comment from our panelists. Dr. Salim, maybe you can tell us way forward through your experience.
Thank you very much. I think one of the things that is coming out is that we need unity. Then after coming together, we really need some stewardship so that we can actually plan for long term. We should know, for example, in the next 5 years, 10 years, what is our position, what do we need really to do to have influence, for example, in policies, in the academic institution, in implementation. We need to know our gaps, especially in our communities. We know most of our communities where we have a lot of challenges. In most of the Muslim counties, actually, they account for more than 50% of the maternal mortality rate, the child mortality rate. So what is it that we need to do differently? How do we get to the communities with simple language? Most of the things that we have been discussing here, what are the takeaway messages for my mother, for the grandmother outside there, so they can actually take control of over and their health. Shukran.
Shukran. Sheikh Rishad, I will come back to you because we need to give you 2 minutes to make a special dua. You're aware of that. Dr. Wajid, in 2 minutes, please, can you give us your closing remarks on how we can move forward and based on your experiences in the UK?
Very quickly, the way you can move forward inshallah, we need to build the infrastructure. As one friend said, and I will finish this, he said the problem with Muslims today, we all want Salahuddin. Nobody wants to be his father. Nobody wants to be his father. So, brothers and sisters, inshallah, being the father was part of the community, inshallah, we need to get people to not sign up, and work hard. If you work hard, there's work you be more organized, reach out to others to vote, inshallah. Just 10x this organization in 2 years, inshallah. I'm just the numbers, but the output as well, inshallah, and the initiative.
Jazakallah khair, Dr. Wajid. We do not take
Doctor, not a doctor who's a Muslim. Get engaged with the local community. Pray in the local masjid. Don't be too busy. You just pass in your car, the Prado, the nice Harrier. We only see you in the car. We only see you in the wedding when you can get time. They say people make time for what they see is a priority. So can your local masjid be a priority? Can you have durus once a week? Be it a Sunday after Maghrib, to tell people our entire community is diabetic and hypertensive. What are you doing about it? You are happy to see them coming to your hospital? Aren't you happy to see them that, that they live a better life because we say it's a lifestyle disease? Can you go communicate that in the local masjid? Can you tell them that after Salat al-Jum'ah, 5 minutes darsa maybe after Fajr? Can we see you in our local masjid praying Fajr? The ladies, where there is a masjid that has a Jum'ah area for the fellow ladies, can you go pray there? Stop being this high-class kind of people. Can you just be a common man like everybody else? That's how you can bridge the gap. It's you doctors to come down to us, not us to follow you up there. It's not possible. Can you just come down to us? Be the, doctor so-and-so, but very close to the community. Who amongst you here can say you really work with the local community? People know you? Yes, there are some of you, mashallah, that do a great deal of that. We have radio stations that offer minutes, but there's no one to go there. There's no one that is offering. There's Al-Haajar TV available, but they can't get you people. You're just too busy. What are you following? What are you, all those operations you want to do? I mean, why were you in this profession in this first place? Maybe we all forgot that. Were you taken so that your parents could say, Mwanangu Daktari? Is it about that? Is it about the DR in front of you? Or is it about service to humanity, service to Allah subhanahu wa ta'ala? Remember, wallahi, you will be remembered with the amount of people that you helped. I remember we were in a talk show somewhere, and people are complaining that the doctor feels if he tells the patient, say, we bana njoo nione hospitali bana, acha kuniuliza maswali mengi hapa hivi. Hii service inalipiwa, Is it about the 3,000 or the 1,500 consultation fee? Or is it about you doing something? The doctors that are not employed right now, why don't you volunteer your services? Why don't you go to these hospitals that need people, just talk to them? Why don't we have a Muslim hospital? Kammp, go, source for funds. Middle East has people that have money, they don't know what to do about it. Go talk to them. Yes, because you're not asking for it. Because you're not coming up with the proposals to ask for it. We have people that help. That brother came and gave so many machines to Coast General Hospital. He can actually talk to his people that think like him and put up a hospital for us. And I don't want to mention hospitals, but we are hospitals that were, this is something else. The hospitals that were built by, donations, they're no longer Muslim hospitals. They're now a profit-making whatever. You talk of them. We don't need to mention them. Some of you were actually sponsored by Muslims. Where is your gift back to the Muslim community? So people are actually bitter. Because somebody militoa shilingi yangu ukenda ukasoma. Leo ananiambia kukuona just to advise me on John hospitali. And then you don't even want to be called Richard, watakuita Dr. Richard. So please, let's come back, let's come down to our people, let's connect to our people. You are so crucial. I tell you, wallahi, if one of you is to take the mimbar, people will not sleep. They will listen to you. So be a Muslim doctor first. Go back, learn about Islam. No Ibn Sina. Ibn Sina discovered 700 diseases and their cure. From where? From tawfiq of Allah subhanahu wa ta'ala, and Allah saw his ikhlas. Al-Razi, most of the medical, most of the things the instruments we use to operate, he invented them. Al-Jabir bin Hayyan is the father of chemistry. When you can't talk about anything in the lab with a titration, discovered by a Muslim. Crystallization, discovered by a Muslim. These are things that we need to tell our people. Having a beard is a good thing. All of them had a turban like me and a beard, for your information. When we graduate, you wear the gown. That's the normal joho that we wear when the khatib does in the masjid, because people who are graduating from the Islamic universities. Medicine is Islamic. Medicine is connected to spirituality. You can't be a doctor if you don't feel God in yourself. That is why people have to go to India. Because you don't bring God in play when you're doing diagnostics. You give people false hope. Well, you know, cancer stage 4, morphine is not working anymore, you still want to take them to ICU. Tell them, Akhoui, right now, just do the talqeen. It's the doctors that are supposed to be giving the talqeen. But you're busy resuscitating somebody that you know is dead. When oxygen is 30%, you know it's not going to go back to 90. You know the patient is going to die. But bado tutakwenda tumfanyie CPR ambazo hazina maana. Afe bila shahada. While at that particular moment, call the people, tell them, gather around him, give him talqeen, say, oh, la ilaha illallah, Muhammad Rasulullah. Are you feeling me? God bless you.
Be a Muslim healthcare worker and not a healthcare worker who is Muslim. That is the message. I think I have about 5 minutes. So just quickly, we will take, I'm getting too different. So we'll just quickly take 2 or 3 burning questions for these 5 minutes. Dr. Ibrahim.
We brought Ustad Rishad as a representative of the community. And that's what people feel and say about doctors and nurses. Questions?
Barakallahu feekum. This is a very, actually, touching moment when you hear the brothers all commenting from different aspects. When Sheikh Rishad says it is wajib, it means it's a must to do it, and if you don't do it, it's a sin. It's beyond, as you said, a must. And when you perform a sin, when you don't think of the person, of the patient you're dealing with, and you're not sincere in managing that patient, apart from getting a sin, you're also doing dhulm. When you do dhulm, there's no barakah in whatever you do. So this is something we must always put in our mind when we're attending a patient. But that comes to another challenge which we find in our society. In a situation whereby we find in our community, we're all Muslims, this is the forum I think we can address it. A brother or a sister is not practicing in an ethical way. Is there a means, do you have a mechanism whereby we can help advise and rectify that person? That is really missing in not only in this society, in all societies. Whenever I ask about this conference, when I ask, Kammp being as a Muslim organization, is there a mechanism we can put to help that person? And because sometimes you find that occurs also in us as topmost consultants, and the younger generation look up and say, wow, look at that person, bedazzled by that person. And in the process, they adopt and they want to copy, emulate that same kind of example of that person. So not only that person doing harm to the patient, is also doing harm to the future generation of our communities. There must be a way we can do that, number one. Number two, prevention is better than cure, we say. What mechanism can we create to prevent so that we can produce, as you said, a Muslim doctor? That is another comment. There are many others. A suggestion final about the health institutions. Biggest thing we said, the biggest challenge is anything is finance. Wallah, we have zakat. We all give out zakat. Can you put a system whereby not all of the zakat, maybe you've got family to take care of, a system whereby a certain percentage of zakat is kept in through Kammp and then utilized. That's how the others abroad do it, and then they help us down here. Thank you very much.
Shukran. Maybe to reduce the burden of the questions, I'll tackle the last one. On the zakat part, just as an information, we are cooperating with Zakat Kenya, which does a very fantastic job in vetting our students for the Al-Ilm Fund program. And some of the issues they're tackling is also medical bills, because these are indebted people. And they do due diligence, and they offer a lot from Zakat Kenya to these things. And this is one of the partnerships that we could, have with Zakat Kenya moving forward. I'll let Sheikh Rishad handle the question of, I don't know whether it was directed to Kammp. We can take up that challenge of the ethics part, inshallah, but Sheikh Rishad, just briefly maybe address that.
Maybe Kammp should actually have its own Muslim scholars, so that today if you want to ask a question, who do you go to? You're a doctor, you're facing a situation on ethics, on ethic issues. So a doctor wants to know, what do I do? Who does the doctor communicate to? So maybe, I've been telling this to Dr. Ashraf, maybe Kammp should have a pool of Muslim scholars that it deals with, so that they can actually cater for that and advise as far as that is concerned. But you see, you guys are learned, alhamdulillah. We don't need to say anything about that. And mashallah, you are privy to information, alhamdulillah. Read about Islam and how to practice as a Muslim doctor, what to do, what not to do. I remember, there are things we should actually let the nurse do instead of you doing it. These are things that impart confidence in people, in our clients and things like that, because sometimes if this is a case whereby there's I know, and this is what I'm saying, we really have to be, why am I saying Muslim first? Why? Because I know I am a man, and this lady, whatever they've come with, it's a lady, and I know a fellow Muslim doctor, there is a lady that can handle this. Say, just pass it over. I don't have to handle it. You see, when you're looking at that barakah that Dr. Ibrahim was talking about, this is where it comes from. I don't need to handle the lady on something that I know. I'll just give you an example, and then you take it home, go think about it. So that we understand the intrigues of, us treating female patients or female patients being treated by a male doctor. When in Sharia, if a Muslim woman dies and there is no mahram to wash her, no one, and there is no female and no mahram to wash her, what is the ruling? Is it the darura for the men to wash her? Or what is the ruling to bury her? A question. Tell me from what you know. How do we just bury her without washing her? Or do the men wear gloves and to wear shades, tufunge macho, What is the ruling? What is the Islam? Who knows the Islamic ruling?
Dr. Shaush, kuna sweet supper for anyone who answers the question. Lollipops.
Who knows the Islamic ruling? Raise your hands and answer. Yes?
Forget I'm a cardiologist.
Jaribu tu.
Lollipops.
It's a darura,
Assalamu alaikum. Thank you so much. I think in that aspect it's a darura, and there's an aspect of Sharia whereby in case of a darura, everything else falls apart and it has to be done.
So you'll wash her?
Maybe, yes.
Okay. So, anybody else has a contrary idea?
But in Deen, what my Ustad told me, it's not sometimes what you think. It needs to be guided by evidence.
So,
an ayah, a hadith, or jurisprudence by ulama. So there might be, the example is if you want to take wudu and I thought you should clean your shoes down, not at the top. But the deen is on the top. So give an opinion.
He said it's darura. Darura tubihu al-mahdhurat wa darura tuqaddar biqadariha. Okay, to make it short, there is no darura in this. You bury her directly, same way, without washing. Simple. You see how you all kept quiet, but why didn't you know? Why didn't you know? So you see how you will base any other decision and maybe you make a mistake? So do you have an excuse of not knowing and you're a medic? Can you go back and read? Some of you have masters in your fields. Can you just do the basics of Islam in terms of your related fields, please? There is no excuse to that ignorance. You have no excuse among Allah subhanahu wa ta'ala, in the eyes of Allah, for that ignorance. Take home that.
Challenge accepted, and I think one of the reasons for the Ibadah-friendly hospital we are trying, it's a lot. We need another session for that, but inshallah we'll look into that. Do you have time for another question?
But this happens. Huh? We frequently see there are some ICU nurses here. People resuscitate and a patient is not covered. So as a Muslim, how many times have you initiated something? Or tell the patient, La ilaha illallah, or Shahada. I know nurses, Muslim nurses, who have made a patient take wudu as they're almost coding. Coding meaning they're going to lose their life. This is a pending code, and a Muslim nurse says, let me make a wudu. I have seen a medical officer, the patient is a female, took gloves and made her go through wudu. Okay? And remind it. So it's possible if you think about it and if you learn. Please.
Mine is just to echo what Dr. Rishad said, that supporting our office as chaplains or learned imams who are working in the hospital as clinical chaplaincy. I think it is our role to teach, to educate, to guide always the doctors whenever they need us, the nurses, wherever we are, and to campaign for every hospital to have an imam or a chaplain or a learned Muslim scholar. Number two is that when I was employed at KNH, I had the same mentality. Coming from the background of Islamic Sharia, madaktari wana kibri, madaktari wako hivi na vile, because they are learned, they were straight A students in high school and blah, blah, blah. But after working with them, at the hospital, highly learned scholars, I've realized that problem is not only on the doctor side, but sisi ambao tumesoma dini. Some of us are very arrogant, and subhanallah, we as people who are learned in religion, we should be the ones to go out and, get, connect with the doctors, get out to them, because subhanallah, after working at the hospital level, KNH, nimekuja kurealize most of the doctors are very humble. Dr. Ashraf, you, Dr. Umar, Dr. Bajabir, very nice people. All the presenters who are here today. So I think it is the sheikhs who have that challenge to humble themselves, come down, and at least so that they can talk with the doctors.
So
he has been indoctrinated.
No. So I'll come in between. We worked with Ustad Rishad during COVID. Okay? COVID was a very challenging time. He is one and the head of COVID team locally. So when you had a patient or a Muslim patient who died and needs assessment on to how to take, wash, bury, we had a team. There's no way those COVID patients could have been treated without the medical team, and there's no way they could have been buried without the Muslim non-medical team. And there were funders for that. There was sandals were ready, a car was ready. There were guys that he never gave a shilling, and we called them at 10 p.m. or midnight, and Dr. Ustad Rishad will come with them. So we need to meet at Mtito. We medical, we come over, because there are things they don't understand. The medical bill is high, something is wrong. What happened? Because during COVID, unfortunately, some of our brothers said, nyinyi madaktari mko makafiri sasa. Nyinyi hamutaki hata watu waswali. Vipi utavunja sunna ya jamaa next to each other? But it's because you don't need to use your lens to see them. See the world from their eyes. They don't know the information you have. Similarly, Sheikh, we don't have the information you have. So please, let's come together. We are in need of your information, and you are in need of our information. So as Kammp, we are ready to facilitate, but we still need to learn till the day we die. Okay, so that's a good gap that is coming up, highlighting the need of me and you to hold hands for the betterment of the community. Okay, we have a last question from Dr. Rukia.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam.
I'm called Rukia. I'm an obstetrician gynecologist. I'm very grateful for this session. I couldn't miss it, although getting late for prayers. It has made me have a lot of tafakkur and tadabbur. First, yesterday, our brother Dr. Ahmed Tahir talked about the Ibadah compliant hospital. As Muslim women, we're having a lot of challenges. I mean, when a woman comes to us, obviously the aura is very important to us. They expect us from day one, whatever we do, our role is to hifadhi them in all ways, whether it's in a normal delivery, whether it's in theater. It's our duty, obligation. Unfortunately, our sisters, we are trying as much, but we don't have the full capacity. For example, when we go to theater, we have female anesthetists, alhamdulillah, now, okay, although they're non-Muslims, but at least. But then now, in terms of capacity building, the scrub nurses are male, we have few female, the technicians are males. So I think we need to start from high school level. We need to start going to the schools, helping these young women make decisions what they want to do. I know young girls doing a lot of baking, a lot of ticketing. I'm not saying that they're not good professions, but yes, I mean, we need to see what our ummah requires. Because at the end of the day, I feel obliged to my God, okay, this woman has come to me, and I feel I have failed this woman. Why? Because I have to actually tell no males to come in. You know, even you see the stretcher bearers, it's subhanallah. You've tried your part, at the end of the day, you feel you have failed this woman. This woman knows she's under anesthesia. You have protected her aura. She has come to you. So I think we need to sit as a Kammp and how to help our sisters, okay, because they look up to us, okay? We, alhamdulillah, now we have different professions, I mean, we have so many subspecialties, women leading in the country. So I think I love this forum. That's why, astaghfirullah, I'm late for my prayers, but I had to give this comment.
Inshallah, you'll pray. Thank you. So we're coming to the end of this session, and one thing, my senior, just today, he told me, yes, when you're coming for this, Dr. Tahir, and he said, yes, you will work, you went to school, you got money, you saw patients, you did a procedure, but there is wajib for the community, and if God tomorrow asks you, yes, you made money, you inherited your son, you gave him whatever, but when God asks you, what did you do for the people? Do you have an answer? Coming to Kammp, whatever, but you have a responsibility as a human being. Someone held your ear, someone told you, don't do this, don't smoke a cigarette, nitakuchapa, nitakufanya nini. There is a community guiding you. Now, who you are today, what have you done for the community? And that's why we have public health officer, we have an imam to represent the community, okay, and we have a doctor in this panel. Dr. Abdullah, please close the session. But whatever we have seen, I would kindly like to recognize the presence of our previous president, Dr. Marjan. Those who are seeing here were elected through his office. Dr. Marjan, please stand up. Thank you very much for the guidance during this conference and up to here. Allah may bless you, inshallah, okay? Dr. Abdullah, over to you, and you'll see Dr. Maalim, who is equal to food. He's here, okay.
The one announcement I've been given. Shukran for giving us your time, to the scholars, to the experts in the various field, Dr. Wajid, who I think might have dropped out. I think we have delivered what we tried. There's a lot to be discussed in this, but I hope you are happy as we are that there's a commitment to do better, inshallah. So I hope we've delivered. We've closed with that. If you're happy, then kindly clap for us. Naam. So Sheikh Rishad will close with the dua, but before the dua, just a few announcements. CPD points will be at the reception desk after lunch, inshallah, for those who need. And then membership, Kammp membership. Please scan the QR code and then you might be able to follow the instructions. Sheikh Rishad, over to you.
Bismillah. We are going to pray, and we are praying especially for Palestine and everything else. اللهم صل على سيدنا محمد وعلى آله وصحبه وسلم. اللهم نسألك بأسمائك الحسنى بصفاتك الأولى فأنت الله لا إله إلا أنت. أنت الأحد الصمد الذي لم يلد ولم يولد ولم يكن له كفوا أحد. يا حي يا قيوم برحمتك نستغيث يا ذا الجلال والإكرام إلهنا وإله كل شيء. نسألك اللهم بأسماء إذا سئلت به تجيب. اللهم لا ترد يدنا صفرا. اللهم لا ترد يدنا صفرا. اللهم لا تجعلنا من الخائبين يا أكرم الأكرمين إنك لكل شيء قدير. اللهم لك الحمد لك الشكر كما ينبغي لجلال وجهك وعظم سلطانك. لك الحمد حتى ترضى. لك الحمد إذا رضيت. لك الحمد بعد الرضا. اللهم لا تحرم علينا قبول دعائنا لأجل ذنوبنا وخطيئاتنا ومعصيتنا وتقصيرنا وما فعل سفهاء منا. اللهم أعز الإسلام والمسلمين. اللهم أعز الإسلام والمسلمين. اللهم أعز الإسلام والمسلمين ودمر الشرك المشركين ودمر الشرك المشركين ودمر الشرك المشركين. اللهم عليك باليهود والنصارى أعوانهم. اللهم عليك باليهود والنصارى أعوانهم. اللهم عليك باليهود الصهيونيين المعتلين. اللهم عليك بهم بكل ما عليك. اللهم عليك بهم بكل ما عليك. اللهم شتت شملهم ومزق جمعهم ورد كيدهم في نهورهم وتدميرهم في تدبيرهم يا أكرم الأكرمين. اللهم اقتلهم عددا ولا تخص منهم أحدا ولا تغادر منهم أحدا. لك الحمد لك الشكر كما ينبغي لجلال وجهك وعظم سلطانك. اللهم انصر إخواننا المجاهدين في فلسطين. اللهم انصر إخواننا المجتهدين في فلسطين وغزة. اللهم انصرهم بنصرك وأيدهم بتأييدك. اللهم انصر إخواننا المستضعفين. اللهم انصر إخواننا المستضعفين في فلسطين وانصرهم في غزة. اللهم قوي مقاوتهم. اللهم قوي مقاوتهم. اللهم تقبل شهادة الأموات. اللهم تقبل شهادة الأموات. اللهم تقبل شهادة الأموات. والبس لباس الصبر للجرحى وكل من يعاني بهذه المشاكل إنك على كل شيء قدير يا نعم المولى ونعم المصير. اللهم نحن معهم في الدعاء. اللهم نحن معهم بالدعاء وإن كان ذلك أدنى ما عندنا ولكن هو أقوى ما عندنا إنك لكل شيء قدير يا نعم المولى نعم المصير. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. اللهم سهل لنا ما نريد ونجنا مما نخاف بفضلك يا لطيف يا لطيف يا لطيف يا لطيف. الطف بنا فيما جرت به المقادير وهون علينا كل عصير إنك لكل شيء قدير يا نعم المولى نعم المصير. اللهم لا سهل إلا ما جعلته سهلا وأنت تجعل الحزن إذا شئت سهلا. اللهم اجعل أمورنا كلها سهلة. اللهم اجعل أمورنا كلها سهلة. اللهم إنا نسألك من الخير كله عاجله وآجله ما علمنا منه وما لم نعلم ونعوذ بك من الشر كله عاجله وآجله ما علمنا منه وما لم نعلم. اللهم اجعل جمعنا هذا جمعا مرحوما. اللهم اجعل جمعنا هذا جمعا مرحوما. اللهم اجعل جمعنا هذا جمعا مرحوما واجعل تفرقنا من بعده مؤيدا معصوما ولا تجعل منا ولا فينا شقيا ولا محروما. اللهم بارك كل من حضر هذا اليوم والأمس وكل من حاضر في الانترنت إنك لكل شيء قدير نعم المولى نعم النصير. وصلى الله على سيدنا محمد وعلى آله وصحبه وسلم. سبحانك ربك رب العزة عما يصفون والسلام على المرسلين والحمد لله رب العالمين.
Shukran, Jazakumullah khair. So the housekeeping announcement will now go for lunch. We should be back here by 2:45. So we are going for prayers and lunch. Okay, so the prayer place is the usual prayer place as yesterday, downstairs, on the ground floor. Shimba for our sisters and Kaya for our brothers. The lunch will be at the same restaurant. Make sure that you have your vouchers. Those who don't have the vouchers, just look for the volunteers. We should be back here at 2:45. We have an amazing session in the afternoon. These are the skills stations where